Hello, good afternoon. We'll be looking at the pharmacology of sulfonamides today, and we'll be using these outline as we get to discuss it. We'll look at the discovery, the basic chemistry, the mechanism of action, the spectrum, the resistance, the adverse effects, the drug class, drug interaction, and the drug combination. Now, what happened for the discovery? What was the discovery about? It was first discovered in 1932 by a man called Gerhard Dunmark. Okay. Now, what he discovered was the drug called protonsil. Now, this protonsil, on further discovery, it showed that it had an active component called sulfonamide. Okay, so these are very basic things to appreciate here. That in the discovery here, it was first discovered in 1932 by Gerhard Dunmark when he discovered protonsil, and the active ingredient in protonsil is sulfonamide. Now, over the years, we have worked in the discovery or in modifying this basic structure called sulfonamide. So that brings me to the basic chemistry. What about the basic chemistry? In the basic chemistry, we have worked on that newer drugs have been made as amino by substituting the amino group, that's the amino group, on these sulfonamide ring. So it's quite important you know that for any sulfonamide drug we're going to be discussing in the nearest subsequent minutes, in a few times from now, that what happened was just substitution of the amino group on their sulfonamide. What's another name for sulfonamide? Another name for sulfonamide is the p-amino benzene sulfonamide. Okay, so it simply means that there's an amine group on the benzene ring coupled with that sulfonamide. So it's just something to have in mind. So that's the basic chemistry. How about the mechanism of action? All right. So in the mechanism of action, what comes to our mind is the synthesis of folic acid. So I should show you something here. Now, we have a bacteria like this. We have a bacteria, and our bacteria, it has its nucleus. This is the nucleus of the bacteria. Now, in the nucleus of the bacteria, folic acid is very, very paramount. Folic acid is a paramount structure. So this is what sulfonamide do. It targets the folic acid in our bacteria. So I call this a bacteria. So how does this happen? Let me write that pathway. Folic acid was produced by converting PABA to DHF and then DHF to THF. What's the full meaning? DHF stands for dihydrofolate. THF stands for tetrahydrofolate. What are the names of the enzymes? The name of the enzyme here is the dihydrothoriate synthase. Okay, while the enzyme here is the one we call the DHF reductase. DHF reductase. Okay, now what happens? What happens is simple, that if we inhibit this enzyme here, we're not going to form all the precursors for folic acid, and then the nucleus is not going to have the integrity it has. And the drug that inhibits this is the family of the sulfonamide. So the family of sulfonamide inhibits dihydrothoriate synthase. While maybe since it's necessary, we also tell you, for the sake of inclusivity, what drug inhibits dihydrofolate reductase? Other drugs, for the sake of MCE, we have about 3 of them. Methotrexate, we have trimethoprim, we have our pyrimethamine, very true. So pyrimethamine. So these are drugs you should remember. Sulfonamide inhibits dihydrothoriate synthase. Methotrexate, trimethoprim, and pyrimethamine, for the sake of inclusivity, although this is where we are really stressing on, but for the sake of inclusivity, you should know these 3 drugs as they inhibit dihydrofolate reductase. Now, I want to say something about sensitized bacteria and bacteria that are not sensitized. Now, when we say some bacteria are sensitized, it means that such a bacteria can produce its own folic acid. It can produce its own folic acid. So if a particular bacteria can produce its own folic acid, it means that it will follow through this pattern, and it means it can be inhibited. But those bacteria that are not sensitized, what happens to these bacteria? These are bacteria that use preformed folic acid. And if something uses a preformed folic acid, you can tell what will happen. A preformed folic acid, you can tell me. If we use a preformed folic acid, what will happen is that folic acid is already there in the nucleus and will not require these steps. And sulfonamide cannot inhibit a precursor steps. So it's very important you have to know that not synthesized bacteria are bacteria that uses preformed folic acid. So sulfonamide have no action on them. Okay? And it's very important you also get to know that sulfonamides are bacteriostatic for your next exam. You only become bactericidal when concentrated. They only become bactericidal when we concentrate them in urine. That's very true. So we are done here with basic chemistry, with this and with this. Now, I must add something again. Toxicity does not happen. Why? Why does toxicity not happen? That the sulfonamide selectively find only bacteria and will not affect human cells. The reason is very simple. Human cells uses preformed folic acid. Folic acid that has been formed already. Preformed folic acid that can either be gotten in diet. Okay? So preformed folic acid is what humans use. So toxicity is never possible. So it has been reduced to the barest minimum. So what have we said? In the discovery, discovered by Gerhard Domag in 1932 when he discovered protoncell. And I said the active ingredient in protoncell is sulfonamide. And for basic chemistry, we have said that the basic thing that happened in there was that we have been able to replace amide groups at different places. Amide group in the p-amino benzene sulfonamide structure. And when we did that, we said that was what really helps to govern things like the solubility, to govern things like the potency and even the pharmacokinetic property. Now, what did we talk about in the mechanism of action? Mechanism of action, I've highlighted that sulfonamide inhibits dihydroxyurate synthase, which were precursor steps for the synthesis of folic acid. And we said, for the sake of inclusivity, other drugs that also inhibit the other subsequent steps like DHFRO were those of methotrexate, trimethoprim, and pyrimethamine. Alright, so now let's go to the spectrum. Now for the spectrum, sulfonamide has been used originally. Sulfonamide had action on gram-positive and gram-negative. That was originally. But nowadays, we have seen that potency has been limited to just a few bacteria. Bacteria like Nocardia, bacteria like Klebsiella, bacteria like H. ducreyi, Haemophilus ducreyi, bacteria like the granulomatous, Alright, the resistance has been also seen in some bacteria. Where have we seen some resistance? We have seen resistance in bacteria like the Neisseria, Shigella, okay? And we have also seen it in bacteria like E. coli. So for your MCQs, these are something to note. Potency has been seen in Nocardia, Klebsiella, H. ducreyi, and Endobatis. Resistance has been seen in Neisseria, Shigella, and E. coli. So that is that for this spectrum. Now, how about resistance nowadays? What happens for the resistance? Now, for the resistance to sulfonamide, what has these bacteria got to do? Now, I write that pathway again, where we say BABA to DHF, and then DHF to THF. And it is this step that sulfonamide inhibits. So what has happened to resistance? How have we developed resistance? Resistance has been developed. Number one, what these bacteria have done is that they have increased the amount of BABA. What they now have done is that they have found ways to increase PABA amounts. Okay? Yes, PABA, increase the levels of PABA. So when we increase high levels of PABA, it makes that we also need an equivalent increase in amount of sulfonamide to achieve the same therapeutic dose. So that's what they have done to resist. So increasing the amount of PABA. What else have they done? They have also altered their enzymes. They have also started using other enzymes. They have altered their enzymes such that sulfonamide cannot come to that enzyme here. Which enzyme was that again? Dihydroxyurate synthase. Alright? And then also, some of them have also learned to use alternative pathways. Alternative pathways. So, alternative pathways for folic acid synthesis. So because of this knowledge, it is now quite necessary that you know what resistance to resistance will say, increase in PABA, altered enzymes, and alternative pathways for folic acid synthesis. As a rule of thumb, resistance to one means resistance to all. Never forget that when we have a resistance to one sulfonamide, it means it is resistance to all. Please remember, it could be as a trick in an MCQ question, an objective question. Resistance to one sulfonamide is, so remember, resistance to one sulfonamide means any other sulfonamide that you will use on that same individual, such a person will also show you resistance. Okay? Now, what are the adverse effects of sulfonamide? For the adverse effect here, I'm going to show you a mnemonic which I've been able to use to remember B, C, H, 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 and N. You can guess. The first N here, nausea and what? And vomiting. Nausea and vomiting. Okay? The N here, neutropenia. Neutropenia. Okay? The H, hemolysis. Hemolysis which could be due to G6PD deficiency. Hemolysis. Here, H, we can also have hepatitis that can be seen about less than 1% of the population. Okay? We see hypersensitivity reaction. For hypersensitivity reactions, what are examples of things we see here? We see things like urticaria. We see things like exfoliative dermatitis. We see things like rashes, Steven-Johnson syndrome, etc. Now, how about C? Crystalluria. 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 And then B here, bilirubin displacement. For bilirubin displacement, another name again, in case you see it in your textbooks here, Kenecterus. Alright. So these are now an acronym to use to remember the adverse effect of sulfonamide. BCHHHN squared. So that is it there. Now I want us to now say something quite interesting. That's the drug class. As we take it again from here. Now what becomes of the drug class in sulfonamide? What becomes of the drug class in sulfonamide? For the drug class in sulfonamide, I'm going to divide them into short-acting. Short-acting. For short-acting, the major example I have here is the one I call sulfa-isoxazole. Sulfa-isoxazole, which has a peak plasma level of about 2 to 4 hours. Short-acting. Okay? Now, I also have an intermediate drug. Now, for intermediate, we have about 2 of them, but their half-life for both of them is about 10 hours. What are examples of drugs here? We have the likes of sulfadiazine. I put this in capital letters so you know what to say. Sulfadiazine, and I also have sulfamethoxazole. Methoxazole. So watch again. Peak plasma level here. So peak plasma level of sulfamethoxazole, peak plasma level should be within about 3 to 6 hours. Alright. Now the next. Now before I go ahead, let me say something quickly. Sulfamethoxazole has been used in combination, in combo with the drug called trimethoprim. Trimethoprim. Good. trimethoprim. For the treatment of conditions like resistant malaria, okay, conditions like pneumocystis, girovacin are seen in HIV patients. Also in conditions like toxoplasmosis. All right. Okay. So the next drug here are the long acting. Now for long acting, we have drugs like the sulfadoxine. So watch this. Sulfadiazine, that has been used in combo with pyrimethamine. And you remember pyrimethamine that was used for the treatment of malaria, or preventive treatment of malaria in pregnant women. Now this one, the half-life here is about 7 to 9 days. All right. Now, what other drug again do we remember? The topical drugs. For the topical drugs, I have the likes of lafenant, I have the likes of silver, sulfacetamide. Okay. I also have. Okay. Now, for this silver sulfacetamide, it has been used for ophthalmic infections. So for ophthalmic infections, you can use silver sulfacetamide. Right. Now, there's one more. The drug that we use for the treatment of rheumatoid arthritis and for the treatment of ulcerative colitis. Now, only one drug is being mentioned here. That is sulfasalazine. Now, for sulfasalazine, it has been used for the treatment of this. So, these are drugs you should remember. Now, so we are done with drug class. So have this picture in mind and then go through it over and over again. Now, for mafenite, it should never use it for deep infections. Don't use it for deep infections. Okay, wounds that are deep, don't use it for it. All right, so this is something you can look at again. Now let's look at the drug interactions. Now for the drug interactions, sulfonamide has a way it does combination. Sulfonamide, it can make combination with the following drugs: oral hypoglycemics. Okay, it has also been used as we have drugs like sulfonylurea. Okay, you can also use it for the hide and toying anticonvulsants. Okay. Now, what it simply means is that if it is used alongside all of these drugs, the effect of sulfonamide will increase drastically. What's the reason for that? The reason is because of two things. Number one, either these drugs will help to decrease its metabolism, so they are never broken down, but they remain active for a long time, or it is going to help to displace it from albumin. It displaces it from albumin, So that way, its effect is really, really powerful. All right? So that's what you should remember. Now, for the last thing here, then we round up all the stories I've said. What do I want us to look at the last? The drug combination. What are the different drug combinations that sulfonamide has undergone? Number one, sulfonamide, that is the example of sulfamethoxazole. Think about it. Where did you see this drug? Was it long? Was it short? Was it intermediate? Was it topical? Was it for the treatment of rheumatoid arthritis? Put it down in the comments, okay? So sulfamethoxazole here, if you make it in combination with trimethoprim, in the ratio of 20:1, you form a combination called cotrimoxazole. All right, And cotrimoxazole has been used for different treating things like respiratory tract infection, UTI, toxoplasmosis, okay, resistant malaria, alright, pneumocystis, zero vision. Good. Now, the next drug combination I want us to talk about is the one of pyrimethamine, plus any of these drugs, or list any of these drugs. Sulfadiazine, and even dapsone. Dapsone was used to treat leprosy. So this and that combination also. So these are different combinations that this one has no special name, but this has a special name. All right. So that's the basic drug combinations that have been there. Now, with this, we come to an end, but I really want you to go through this again. Comment your thoughts about the question I asked over there also, and then also share this video with your friends, like, and then subscribe. Do have a nice time. Bye.